Good evening and welcome to the DeBakey CV live heart failure hour, and I'm your host Imad Hussain. Today we have a very interesting topic for presentation and discussion: new avenues in heart failure with preserved ejection fraction. Now I would like to start by introducing my highly esteemed colleagues who are on the panel today. Really in no need of introduction, but just for formal purposes, I have on my left Dr. William Zoghbi, who is the professor and chairman of the Department of Cardiology and Elkins Family Distinguished Chair in Cardiac Health, Houston Methodist DeBakey Heart and Vascular Center at the Houston Methodist Hospital. And joining me virtually, I have Dr. Anita Deswal. We are very fortunate to have her. She is the Distinguished Chair, Department of Cardiology, and Professor of Medicine at the University of Texas MD Anderson Cancer Center. And welcome, Dr. Deswal. So, without any further ado, we have a lot of material to cover. I would like to start off by going over a case presentation to sort of highlight a typical case of heart failure with preserved ejection fraction. I have my slides. So we start off with the case. This is a 65 years old female who's been having progressive dystonia exertion and chest tightness for gradually progressive over a year and a half. Overall would be classified as NYHA class 3. She has had prior hospitalizations for heart failure. She also has a history of chronic atrial fibrillation and is on a rate control strategy as well as warfarin for anticoagulation. You can see her physical exam shows a blood pressure that is 136/84. She is mildly obese. She has elevated neck veins to the angle of the jaw and minimal edema in her peripheral extremities. Her labs show an NT-proBNP of 627 with a creatinine of 1.7, which is elevated, a hemoglobin of 15.6. Her cardiac medications include warfarin, Lasix 40 milligrams daily, lisinopril. She's on a beta blocker at 50 milligrams daily, lovastatin, and glipizide 5 milligrams daily for diabetes. This is a representation of her EKG. As you can see, it shows rate-controlled atrial fibrillation. There's evidence of a right bundle branch block and perhaps a left anterior fascicular block, making it a bifascicular block. So this is a still frame of her apical four-chamber image. And on the left, you can see that the normal LV size and EF is 55%. The LA volume index is severely elevated at 72 mLs per meter squared. Her diastology, mitral valve inflow, as well as tissue Doppler showed deceleration time of 140 milliseconds and E prime tissue Doppler velocity of 0.04 meters per second, or 4 centimeters per second. And her EE prime, as you can see, is 32. If you look at her RV hemodynamics non-invasively, you can see that her estimated RV systolic pressure is 34 millimeters of mercury. Her TAPSE, which is a measure of longitudinal RV function, is suppressed at 14 millimeters. And just to point out that you can look at this tricuspid valve envelope, that it's not complete, and so is potentially an underestimate of what the estimated RV systolic pressure is. She underwent cardiopulmonary exercise testing as part of evaluation of dystonia exertion. As you can see, her peak VO2 is 10.8 mLs per kilogram per minute. Generally speaking, in our heart failure world, if someone is less than 14, we consider transplant evaluation. It's 49% predicted. Her RER is 1.23, and RER is a measure of how adequate the patient did in terms of her exercise. Was it an adequate test or not? And an RER greater than 1.15 is considered normal, so you can see it's an adequate effort. VE/VCO2 is something that it's a marker of ventilatory inefficiency, and 34 is the magic cutoff number that we use for above which it is abnormal. As you can see, it is a measure of, some people think it is a measure of RV function as well. So VE/VCO2 is 39. Peak heart rate she achieved was 153 beats per minute, and her peak systolic blood pressure actually was blunted, and in fact it dropped with exercise. This is a representative images of her coronary angiogram. As you can see that there is no significant coronary artery disease. So patient did proceed with right heart catheterization to define further what was the reason for limitation of her peak VO2. And so as you can see on resting hemodynamics, her mean RA pressure is significantly elevated at 15 millimeters. Mean pulmonary capillary wedge pressure is 23 millimeters of mercury. Mean PA pressure is severely elevated at 50 millimeters of mercury. And if you look at the transpulmonary gradient, the difference between the two, you can see it's 27 millimeters of mercury. So anything for our audience over 12 millimeters of mercury is considered significantly abnormal. Cardiac output was reduced at rest at 3.9 liters per minute, giving her a pulmonary vascular resistance of 6.9 Wood units, the normal being actually less than 1.5, but for purposes of clinical management, less than 3 Wood units we consider as acceptable. LV EDP was also estimated at 25 millimeters of mercury, which is not very different from the mean pulmonary capillary wedge pressure as measured by the right heart catheterization. Now, as a result of these high filling pressures and severe pulmonary hypertension that was found, the patient underwent an inhaled nitric oxide challenge. Now, at a later point, if we have time, we can discuss if this was the right mode of stress. But nevertheless, this is what was done. And you can see the mean pulmonary capillary wedge pressure increased to 36 millimeters of mercury. Mean PA pressure came down to 45 millimeters of mercury. And now if you look at the difference between the transpulmonary gradient, it normalized by inhaled nitric oxide, and the cardiac output dropped with this provocative challenge. So now your PVR calculated is 2.68, which is less than 3 Wood units, sort of telling you that in fact the precapillary component of pulmonary hypertension was in fact reactive, and truly this is group 2 pulmonary hypertension or pulmonary hypertension that is predominantly driven by elevated filling pressures. This is a diagram representing her wedge tracing on the left, and on the right you can see with inhaled nitric oxide, what you see now is very prominent V waves, sometimes hitting up to 60 millimeters of mercury, which is considered very prominent. Just to let you know that her echo should not show any significant mitral regurgitation, which is another cause of prominent V wave. And sometimes an acute VSD can cause prominent V waves as well. But the point is that in the absence of MR, this suggests very non-compliant, either left ventricle, left atrium, or both. So this is the case presentation that I wanted to share with you. After that, very briefly, before moving on to our panelists, in order to discuss the scope of the problem of heart failure with preserved ejection fraction, some touching upon something about the unique pathophysiology, and some misnomers regarding the term heart failure with preserved ejection fraction in a very brief manner. So as you can see, this is I'm showing you data from the cardiovascular health study from the NHLBI. Heart failure with preserved EF or HFpEF is a disease of the elderly. In this indwelling community population, you can see that the prevalence of heart failure overall was 8.8%, but 80% of that had normal EF or EF defined by EF greater than 45%. So it's predominantly a disease of the elderly. That is the first point. The second point is it is a disease that is defined by comorbidities. On average, each patient that is diagnosed with heart failure preserved EF has on average 4 comorbid conditions. In particular, that are very, very worth highlighting are hypertension, diabetes, obesity, chronic kidney disease, and anemia. If you look at the cardiovascular comorbidities, they are also very common, including coronary artery disease, hypertension, as I've already mentioned, and atrial fibrillation. So much so that 2/3 of patients with HFpEF at some point in their lifetime either had AFib or currently have AFib or will develop atrial fibrillation. Now, when I talk about HFpEF being a disease of comorbidities, then it makes sense to try to understand a unique pathophysiological insight into HFpEF. If you take a look at these comorbidities, whether it's obesity, hypertension, hyperlipidemia, COPD, CKD, stage 3, etc., you can consider this as comorbidity-driven microvascular inflammation. These chronic diseases set up a low-grade systemic inflammatory process in the body, including IL-6, TNF-alpha. Downstream, they have 2 effects. One is that they lead to inflammation within the myocardium via the TGF-beta pathway. They can cause, it's the profibrotic pathway. The second thing is they cause endothelial dysfunction, and they result in, this low-grade inflammation results in creation of reactive oxygen species that scavenge nitric oxide, which is a very favorable pathway in heart failure, and they downregulate the nitric oxide pathway downstream, resulting in hypertrophy and stiffness and fibrosis. Just a sort of a model to think about as we move along. This is a misnomer that I want to clarify before we get into our discussion. Heart failure with preserved ejection fraction does not equal diastolic dysfunction. They are not the same. Yes, on to the left you can see, yes, HFpEF has diastolic dysfunction, but like I told you, it's a systemic process. So it also causes vascular stiffness. It also involves the conduction system. So there's evidence of chronotropic incompetence. And in fact, if you look in echocardiographic and other studies, they actually have a reduced systolic reserve. So if you looked at LIVESTREAM, it would be abnormal in patients with heart failure preserved EF. So it is not equal diastolic dysfunction. This is a misnomer. There's much more abnormalities that you would see in heart failure with preserved EF. Lastly, I would like to conclude by saying that HFpEF is now the predominant form of heart failure in the world. It has surpassed heart failure with reduced ejection fraction, no matter whether you look at the inpatient, outpatient, or community-based population. And this last slide, I wanted to highlight a concept that from the 80s to 2000s, if you look at the secular trends in the prevalence of HFpEF, they have increased over time. And one of the reasons is because the comorbidities have increased over time. There has been an obesity epidemic, hypertension, diabetes. They have increased over time, and hence HFpEF has increased over time, and now is a predominant form of heart failure. So with that, I would like to ask Dr. Zoghbi. Dr. Zoghbi, can you tell us, now we've seen a case of heart failure preserved ejection fraction. If someone has shortness of breath with exertion, and you're suspicious of HFpEF, how can we go about trying to evaluate someone for heart failure preserved EF?
Obviously, this is the crux of the question and the problem that we're dealing with. First, it's a pleasure to be with you.
Thank you, sir.
Imad. And I think, to me, I'm not a heart failure specialist, but I'm a clinician, and I'm very pragmatic as to what the situation is. Situation is here, we're defining normal or preserved ejection fraction in a syndrome of heart failure. Truly, this entity is a syndrome.
Correct.
Of multiple entities, multiple comorbidities. And if you see that obviously aging is a factor, it is not much of a surprise that this entity is gradually increasing over time. With increasing aging, you have more comorbidities. The question is, how do you evaluate? It's very easy to evaluate an ejection fraction. The harder portion is to evaluate whether you have high filling pressure non-invasively. Okay. So if you look at, and I don't want you to go through every little detail on this slide, which is busy, but there are two criteria or algorithms, if you will. I'm going to delineate mostly the one on the right with more. But if you look at them, they tell you something about clinical history, but importantly, to be able to get to whether you have high filling pressures or not, we go to some non-invasive or metabolic changes that can occur that tell you something about filling pressures of the ventricle. So from a functional point of view, if you take a look at this slide, so I picked basically one of these classifications, which I'm leaning more towards because it gives me a range of where we are. On a functional status, and this is by echo Doppler, and that's why, Imad went through this case that we had this morning or this afternoon. Septal E prime and lateral E prime, meaning tells you something about relaxation of the heart, if the relaxation is low, below 7 or below 10. And the TR viscosity tells me something about PA systolic pressure, inferring that maybe the elevation of PA systolic pressure is secondary to filling pressure of the left ventricle. And these are rather specific, except for the TR criteria. Morphologically, so indirectly, if the left atrium is quite large, particularly in sinus rhythm, and this is the LV, the LA volume index of greater than 34, or if you have some hypertrophy, left ventricular mass index, that's an indirect measure, if you will, of filling pressures of the ventricle. From a biomarker point of view, nowadays we have NT-proBNP and BNP that we could use to tell us something about high filling pressures. So I want you to think about the clinical scenario, somebody coming in with dyspnea. These are the things that you would do non-invasively to try to see what the situation is. And some of these could be very diagnostic, just like the case we had, where the parameters are way out of proportion. So under major and minor criteria, the major are mostly diagnostic, I would say. The minor, which gets 1 point, is borderline. So you're really not sure what the situation is, where the E over E prime is between 9 and 14, and the left atrium is enlarged but not huge, and NT-proBNP is elevated but not that elevated. And I think you start combining the situations. Personally, I think in those situations, you prefer to have some invasive way to figure it out and either at rest or stress. So to summarize, some of these diagnostic criteria you'd use obviously clinical, in addition to echo Doppler parameters. And the echo portion is the structural, the functional is the Doppler parameter, and also combine that with NT-proBNP or BNP. Okay? So how do we go by an approach to diagnosis? So we talked about the breathless patient, some clinical assessment. And you need to know that the reason why the entity is not called diastolic dysfunction and we went by a measure of preserved ejection fraction is there's a lot of controversy whether an ejection fraction of 55% is normal systolic function. And that's part of the reason. So it's much easier to balance that because people argue that many of these entities, although the EF is about 50% or 48%, is that there is some systolic dysfunction component that is occurring already in addition to the diastolic inherent component that there is present there. So we'll go chest x-ray and echocardiogram. Echocardiogram is truly the crux in this situation. And then you get the scoring, basically looking at all these parameters. If it is very high, you have the diagnosis truly. If it is very low, also you have a diagnosis. And if you're intermediate, you'd like to do more to be able to help you out. Most likely some invasive parameter, either at rest or during stress. And this is the stress portion. You can have a stress echocardiogram. And in a stress echocardiogram, what you're going to be looking for are two things. Remember, we have a normal ejection fraction. Obviously, if ischemia occurs, then you have an ischemic component. But if there's no ischemic component, you look at what happened to the mitral E to E prime ratio. If it is quite high, greater than 15, you got most likely the diagnosis. This is paired with the TR velocity telling me that there is some pulmonary hypertension occurring during exercise. I have to caution you that particularly that these measures are in a supine position, and when you exercise in a supine or semi-supine position, PA pressure goes up. And in normal women in 60 some years of age, and we've looked at these data, the PA systolic pressure lying down, exercising at peak exercise could be 50, 55, at times 60. So this is not specific. It's sensitive, but not specific. The more specific one is E over E prime. And if you're still wondering because patient is neither responsive to therapy, etc., don't hesitate to do some invasive measure to see what the situation is. And on the bottom part of this slide is the hemodynamic, the invasive hemodynamic. If you have resting hemodynamics that are pointing to high filling pressures in such a patient, you have the diagnosis. You really don't need an exercise hemodynamics. Yes, you can exercise them. We've done many of them here. And you look at your PCW, if it's greater than 25 or so during exercise, you can do a bicycle exercise most of the time. I think that's probably the way to go, in the catheterization laboratory. Hopefully that was helpful, Imad, right? And this is an example of such a patient. You can see this is the diastolic stress test. On top is rest, and where you have the E prime of 5, certainly depressed diastolic function, irrespective of age. It is so low. E of 50, so E over E prime is about 10. TR jet is 2.6, which is still in the normal situation. But during exercise, and most of these patients can be symptomatic during exertion, E over E prime goes up to 19, and a TR jet about 3.5. So I rely much more on the E over E prime, unless the TR jet is exceedingly high, then you feel comfortable with that.
Okay.
All right?
Yes, sir. So heart failure preserved EF, Dr. Zoghbi, is basically what we talked about, comorbidity-driven HFpEF is basically a garden variety of heart failure preserved EF. Question I had was, what about some of the mimickers of heart failure preserved ejection fraction that may be a different underlying pathophysiological entity altogether and likely to have different treatment modalities, and they may respond to them? So any thoughts about...
Anytime you have a preserved ejection fraction with heart failure syndrome, that's what we're talking about. You have to look at these entities which are on your slides. They will give you the syndrome of heart failure preserved ejection fraction, but you hope that some of these are modulated one way or another. I'll take the extreme of an infiltrative disease nowadays with amyloid or hemosiderosis, right?
Yes.
These are the things that could be modifiable, and I think the best testing nowadays an MRI for either of these situations.
Yes.
Hypertrophic cardiomyopathy is easy to diagnose because you have significant hypertrophy in these situations, and you may not, that is a little bit more obvious whenever you have hypertrophy and you want to make sure there's not hypertensive heart disease, etc. Pulmonary arterial hypertension, constrictive pericarditis, high output heart failure, we diagnose those from time to time, and these could be because of shunting, either induced, meaning for renal patients, or acquired, so make sure you listen to patients, but you'll have the high output situation where pretty much all the chambers are enlarged. Right ventricle, right atrium, left atrium are enlarged. To the eye, they may not look different because all of them are enlarged, but you see a high output situation, so at times you may want to say, this is a high output situation, so the clinician should help out in this situation. Valvular heart disease, much more easier to diagnose, obviously, with echo Doppler, in addition to everything else. Coronary disease, during your stress, you have to exclude all these, pulmonary embolism and right ventricular myopathy. So they will give you that. At times they could be a mimicker, but at times they truly can give you the HFpEF. But you want to make sure that you're not missing something that you could truly treat. As we will know from Dr. Deswal, we have challenges in that therapy, right?
Absolutely. Thank you so much, Dr. Zoghbi. That makes a lot of sense. So just to summarize for our audience, that basically once you have made a diagnosis of heart failure with preserved ejection fraction, you want to look at the mimickers of HFpEF that are not garden variety HFpEF. And like Dr. Zoghbi so astutely pointed out, the cardiac MRI, you should have a low threshold to perform a cardiac MRI, especially if you see evidence of left ventricular hypertrophy. As a matter of fact, recently there was a published publication on heart failure preserved patients on autopsy specimens. There was a 10% incidence of senile type TTR amyloidosis. And so this is something you can miss. So cardiac MRI is important. Ruling out coronary artery disease or ischemia is important in every patient, and then use your index of suspicion based on comorbidities. For example, just as a brief example, someone has bilateral carpal tunnel syndrome and orthostatic hypotension. These are some clinical markers that may help you point towards cardiac amyloidosis, and so on and so forth. So now I'm going to move gears, and before I do that, guys, the audience, if you want to have live questions, you can text DeBakey to 37607 and text in your message in form of a question, or you can go to pollev.com, pollev.com, enter DeBakey, and then you can pose your question there. So I would like to shift gears and move on to Dr. Deswal, who's joining us virtually. Dr. Deswal, please tell me, once we made a diagnosis, like Dr. Zoghbi really in a good amount of detail pointed out how to go about diagnosing heart failure preserved EF. Now we made a diagnosis. So what do we do about it? How do we treat this?
First, thank you, Imad, for inviting me to join the panel, and it's a pleasure to share the stage with Dr. Zoghbi. So this is the difficult part. I think diagnosis is the first difficult part because we do have a lot of patients who are short of breath, and to try to figure out what is going on is often an issue. Of course, there is that garden variety of HFpEF or HFpEF, which patients are short of breath, but they also have volume overload. And that makes it a little easier to at least diagnose. Now, the question is what to do about it. And first, we use our general principles for heart failure. So if a patient is volume overloaded, of course, we do diuretics. Everybody knows that. But then what? And, we had sort of gotten spoiled with the data we have for heart failure with reduced EF, where we had a number of clinical trials that showed that several neurohormonal modulators in the form of ACE inhibitors, ARBs, beta blockers, mineralocorticoid receptor antagonists, as well as then ARNIs, all led to a reduction in mortality and heart failure hospitalization. And so the first reflex was to think that HFpEF is just another end of that same spectrum of heart failure. And so what worked in HFrEF should work in HFpEF. But we haven't had that kind of luck. So this is a synopsis slide just pointing out that we've done several trials with neurohormonal modulators in HFpEF. The first one was CHARM with candesartan and ARB. There was iPreserve with an ACE inhibitor. And then there was iPreserve with irbesartan. And then we had more recently the TopCat trial with spironolactone. And although all of these trials were really neutral as far as benefit or harm, I think when we have a neutral trial and we don't have a treatment, we try to look further. So, for example, in the CHARM trial, there was a very borderline effect, about 15% reduction in the overall events, although not statistically significant. So we looked at dividing the composite up into heart failure hospitalization and mortality. We found maybe there was a slight benefit in heart failure hospitalization. Then in TopCat, even though, again, overall neutral, we looked at the components of the composite endpoint. And again, heart failure hospitalization seemed to have some benefit with spironolactone, although the overall primary endpoint was neutral. And we really shouldn't be looking at the secondary endpoint. And then we also tried to look further and said, what about regional differences? Because it was found that patients who were treated in the Americas versus those treated in Eastern Europe and Georgia, for example, there were differences in event rates, even in the placebo group, such that patients treated in the Americas had much higher event rates. And so the thought was, did some of the patients that got into trials more from Georgia and Eastern Europe, did they really have heart failure, or were they just short of breath hypertensive patients? And so looking at the Americas in the higher risk population, we found that maybe there is a benefit of spironolactone. That's why when the guideline update came out in 2017, there was a very weak recommendation, a 2B recommendation, which really means we're on the fence. We're not sure. Maybe the benefit seems to outweigh risk to some extent, but a very weak recommendation that spironolactone could be considered in HFpEF to reduce heart failure hospitalizations, as long as the patients met the criteria for study entry, had elevated natriuretic peptides, did not have evidence of hyperkalemia and were monitored, the GFR was not under 30. And then after that, when we realized the neurohormonal antagonists are not working, we did several other heart failure trials, smaller trials looking at nitrates, for example, in the NIH network. We looked at sildenafil in the RELAX study, but most of these trials, again, did not appear to show benefit. Next slide, please. Okay. And then the most recent one was the ARNI trial, Paragon HF. We had good results with the ARNI in heart failure with reduced EF. So again, we thought maybe we would get lucky, and there was an initial phase 2 study called Paramount, where the ARNI was associated with a reduction in NT-proBNP at short-term follow-up. So this trial evaluated sacubitril valsartan, or the ARNI, against an ARB, valsartan. And what they found at the end of the trial was really there was a very modest effect, if any, but it did not reach statistical significance, with a hazard ratio for the composite of mortality and total recurrent hospitalizations being 0.87. So really, if it had reached significance, which it didn't, and therefore these are all now guesses, there was a very modest effect, and most of it was driven by some possible benefit on heart failure hospitalization. Next slide, please. And again, when you looked at the number of secondary endpoints, which really don't have any p-value left, given that the primary was neutral, but it's put out there, and that's why I wanted to go over it. There seemed to be marginal benefit in quality of life, possibly New York Heart Association class, but again, given the primary endpoint was negative, we really can't put much stock into these secondary endpoints. And next slide, please. And one thing that came out of all these neurohormonal trials, when they looked at CHARM, which had included patients with an EF over 40%, and the TopCat, as well as the ARNI trial, which had included patients with EF of 45% or over, if there was any benefit, it appeared to be more towards the lower end of the EF spectrum, which is more in the 45 to 50 range. Even the recent Paragon heart failure trial, when they did subgroup analysis, they found that if you looked with a median EF under 57, that was maybe there was some benefit there. So I think what it's telling us is maybe that range of 45 to 50 or 40 to 50, which is included for trials of HFpEF, may not be the right thing to do to lump these patients into preserved EF. And as Dr. Zoghbi pointed out, there already is some systolic dysfunction going on. And maybe these patients behave more like heart failure reduced EF patients, and it is possible that there may be some benefit of the RAS antagonist in these patients. We don't have any clinical trials done or completed in this group, but that was a thought that's come forward putting all these trials together. Next slide, please. So as I pointed out, what do we do in this day and age when the major trials have been neutral? One, we said, was use diuretics as needed for volume overload. The second thing we shouldn't forget is the treatment of hypertension. Again, this may not be across the board. It may be there's that subgroup who have hypertensive heart disease, LVH related to significant hypertension. And really, we should push to probably get that blood pressure down below 130 systolic, just like the newest or the latest guidelines recommend based on the SPRINT trial. And if one remembers from SPRINT, the maximum benefit that was seen in the composite endpoint or in the secondary endpoints was reduction in heart failure hospitalization. And so I think control of blood pressure in that particular subgroup is really important to either prevent HFpEF or to decrease heart failure hospitalizations and maybe even mortality in the longer term. Next slide, please. And then one other approach that has been successful or shown promise has been using ambulatory hemodynamic monitoring with what we currently use as the CardioMIMS device, which is implanted in the cath lab into the pulmonary artery, and this then measures pulmonary artery pressures, and you can follow the PA diastolic pressures as a surrogate of the wedge pressure and monitor those remotely and try to adjust medication. So this was the CHAMPION trial, which had looked at both patients with heart failure with reduced EF and HFpEF, and demonstrated the benefit in the arm where therapy was based on remote monitoring of the hemodynamic pressures. And when they took the subgroup of about 120 patients with HFpEF, again, the HFpEF in this group included patients with an EF over 40, so not quite HFpEF if we were to stay with the strict criteria. But it did, again, demonstrate an improvement in outcomes. So even though we say we don't have treatments for this group, there are probably some meds, just the common usual group of diuretics, as well as blood pressure meds that we could use to improve outcomes until we have some more definitive therapies. And then one looks at, okay, so where do we go now from here, given that none of the large major trials have helped us? And what has become apparent is that HFpEF is not a homogeneous disease. As we have come to realize with HFrEF, where there is the LV dilatation, the LV remodeling, and neurohormonal blockade seems to work irrespective of the etiology of HFrEF. In HFpEF, these patients are very different. And we therefore may have to phenotype them somewhat better in order to be able to develop treatments for subgroups rather than trying to find one treatment that goes for all the patients. So for example, after we've treated them with diuretics and treated the hypertension, paid attention to the comorbidities of whether it's coronary artery disease and requiring revascularization, AFib with RVR, treating the rapid ventricular rate, and maybe even trying conversion to sinus, although we don't have trials that tell us that in this patient group across the board, that's a good strategy. But we all know of patients who do not tolerate going into AFib, and if we can keep them in sinus, they seem to do better. And then maybe the neurohormonal blockade may work towards the lower end of EF, so 45 to 50, 45 to 55. Again, this is just thought-provoking. I don't have actual clinical trial data in just that group of patients to be sure. And then we start to think of various subgroups of this population. So is this a group where on invasive measurements, the LA pressures are really much higher than the right-sided pressure, so there's not RV failure, there's not much right-sided heart failure, but these patients have a really high wedge pressure and get very short of breath doing any activity. So maybe in this group, we could consider using something like MRAs or ambulatory hemodynamic monitoring to really tell us what their filling pressures are so we can target those, because the right side and the clinical exam may not demonstrate volume overload. And the other device that's being studied in this group of patients is the interatrial septal device to try to create an iatrogenic shunt between the left and the right atrium. And this is not a big shunt. It's usually in the range of about QPQS of about 1.2 to 1.3. But this device is placed somewhat like an interatrial septal occluder device. The only thing is this is actually the opposite of that, where you're creating a little connection between the left heart and the right heart at the atrial level. And flow only goes from the left side to the right side. And this may help to sort of decompress the left atrial and the left ventricular diastolic pressures. The thing to remember, and again, this is in initial trials, this has shown some promise as far as reducing filling pressures and making patients feel better at the end of 1 year, but again, in very small phase 2 trials, and there is a larger phase 3 trial, the LAP heart failure trial, or the LAP reduced heart failure trial that is ongoing. The thing to remember with this device, we will have to phenotype our patients because we can't use it across the board. If the patients already have evidence of RV failure, and we start to create a shunt from left to right, we'll only worsen that. So this may be for a particular subset of patients. Then there may be that group which is more the garden variety of high blood pressure, high volume. And maybe here, besides our usual treatment, there are ongoing trials with SGLT2 inhibitors. And as all of you know, there's been a lot of excitement, at least in the HFrEF world, as far as SGLT2 inhibitors with the DAPA-HF and the Emperor Reduced trial demonstrating improvement, mainly in heart failure hospitalizations. And there are ongoing trials. There's DELIVER-HF and Emperor Preserved, which are looking at empagliflozin and dapagliflozin in preserved EF. So we await those results. Some of these patients that are class 3 have been in the hospital recurrently and have sort of very labile filling pressures. They go into pulmonary edema fairly easily. This may again be a group for the ambulatory hemodynamic monitoring. Then we have the exercise intolerant group. They have normal filling pressures at rest, and they require the provocation either at cath or a diastolic stress test, where when you exercise them, their filling pressures go up. We don't have the treatment for them at this moment, but again, there was a thought to using nitrites because it's a nitric oxide deficient state. The Indy heart failure trial, which looked at nitrites, did not show benefit in increasing exercise tolerance. Maybe these patients may be candidates for exercise training. There have been some smaller trials, especially from Delane Kitzman group, that have demonstrated improvement in exercise capacity using exercise training. That may be a way to go. And then there's, of course, this hardest group, and that's probably the group that you saw, which Dr. Hussain presented, who have combined pre and post capillary pulmonary hypertension, have evidence of RV failure and very high left-sided pressures. And, we treat them in the usual ways. They, again, may benefit from hemodynamic monitoring as on the outpatient side. There was a recent study presented at the HFSA, which just happened over the last weekend, where they were thinking of splanchnic nerve ablation. The right greater splanchnic nerve was ablated with a thought to increase the venous capacitance in the abdomen and the splanchnic circulation, and sort of decreasing preload to the right side. Again, I think they only did 11 patients in a non-US site, but that is something that is being evaluated. And then some of the other agents, MRAs, the spironolactone, may be a good thing to try for these patients. And then there's that metabolic obese phenotype, which is patients which we see they either have frank diabetes or they may not have frank diabetes but have insulin resistance, are obese. And this is that inflammatory phenotype that Dr. Hussain mentioned. And again, what do we do with these patients? We're not sure yet, but this is definitely a large group of patients we see. And maybe weight loss may be beneficial in patients that are morbidly obese, whether it's through bariatric surgery, maybe through the use of GLP-1 agonists, use metformin in this patient population, and SGLT2, which is thought that may have modulate some beneficial metabolic effects, may be useful too. An interesting thing that has been brought up is in the morbidly obese population, where it's not just the heart that has an issue. There is an increased circulating plasma volume, but there's also the pericardial restraint. There's possibly an abdominal and a chest restraint, which then limits the space that the heart has. So it's almost like constrictive pericarditis, but it's due to an increased volume state and extra cardiac restraint. And, there have been some novel therapies suggested for this, with trying to go in invasively and take care of the pericardial restraint, sort of making a cut in the pericardium. Again, these are experimental at this point, but maybe a way to go. And then, as was already discussed, we should definitely try to make the diagnosis of amyloid, because probably about 15% of these patients may have amyloid as a cause for their HFpEF. And as you know, tafamidis is available for the treatment of TTR amyloid. Always remember, we need to, in any case where we suspect amyloid, need to rule out AL amyloid right away. So light chain immunofixation, as well as the lambda kappa light chain ratio may need to be looked at. So that always has to be done, even when you're working up the patient for TTR amyloid. And then, of course, HCM, and we know all the therapies we usually use for HCM, but recently there was a trial presented at the ESC meeting where they looked at a myosin inactivator or a myosin inhibitor, mevacaptan, and it reduced significantly the outflow gradients in HCM. So again, these are some things on the horizon, but it has become clear that we may need to phenotype our patients better and then study them in subgroups rather than going for one strategy fitting all. Hussain, I think I'll end with that and open it up for questions or comments.
Yes, no, thank you very much for an overview of what therapeutic options we may or may not have. I think the crux of the matter seems like that HFpEF it's a hodgepodge of different types of diagnoses, and we need better phenotyping and individualized therapy to what it may, to who may benefit from a particular, rather than throwing one agent at all people that have HFpEF. So I think we should open this up to our audience. We already have several questions. I would like to start with some that are geared towards Dr. Zoghbi. Dr. Zoghbi, there's a question, is there a role for longitudinal strain in the evaluation of patients with heart failure with preserved ejection fraction?
I would say possibly, and let me tell you why. It won't help you in the diagnosis. It really won't help you in the diagnosis. And why? Because if you think about all the comorbidities that you have that are producing this syndrome, right? Most of them will affect global longitudinal strain. Hypertension will reduce it. Left ventricular hypertrophy, it doesn't have to be immense, but it will reduce it. Any infiltrative disease may. And if you have people in the ejection fraction range of 50-55%, their usual global longitudinal strain is depressed somewhere in the 14-15 range, okay? And remember, what you want here is you want some index of high filling pressure. And we don't have that index. The others are indirect, right? So if I have a big left atrium, that tells me something about it. The one that tell me more about pressure are the filling dynamics, right? Mitral inflow, tissue Doppler, indirectly the PA pressure. There are some data regarding left atrial strain as opposed to global longitudinal strain of the ventricle, and that may be helpful. It's still too early. So I'm cautioning you, because not infrequently in these patients, you're going to see something on the lower end of normal or mildly abnormal. I'll take an example, right? Somebody with significant hypertrophy, their GLS is usually reduced, while their ejection fraction could be 70%, 65%. And why? Because there is less descent of the base. Radial shortening is much more increased as opposed to longitudinal strain, which is deformation in the longitudinal plane, because of changes in the fibers and which ones are more affected than others. I want to go back. I have a question for Dr. Deswal and you, both of you. Maybe you're looking at the wrong endpoint. And that's why most of your trials are negative. You're aiming at the endpoint, which is similar to reduced ejection fraction, where the heart is very depressed because of either coronary disease or some myocarditis in the past or something like this, okay? Where progression to severe heart failure and cardiogenic shock is high, and where arrhythmias are significantly induced, right, at the lower end, where you can have an event, a big event. So if you're aiming, to me, if you're aiming for mortality, these are the ones that would influence mortality with all your drugs. This patient population, and your last slide is the most beautiful, because it tells you that you may be treating different entities here. It's just like treating somebody with a bacterial infection with one type of antibiotic, and you're not aiming it for a specific treatment.
Organism. Yeah.
So maybe, and actually from a patient, and what I'm saying is that mortality may not be that influenced in this population because we're dealing with an older population with many comorbidities that affect ultimately your mortality.
Sure.
Right? You're not, with trying to improve their symptoms, you're not going to affect ultimately what they do. And that's why most of the signals you're seeing is in heart failure hospitalization. And patients in this disease probably will care most about their symptoms, whether their class of heart failure has improved a little bit, whether I could be a little bit more mobile as opposed to more sedentary, and the mortality portion. Maybe we should look at that part of quality of life as opposed to, because you're getting the signal from hospitalization as opposed to a mortality endpoint.
Sure. Dr. Deswal, I'll let you take it first.
Sure. I think, Dr. Zoghbi, that's a very valid point. And this has become the norm. And especially as new drugs come on, I think they have a concern with the FDA and how the FDA should probably view these meds, where mortality may be an important safety endpoint, but it may not be in the primary efficacy composite endpoint. I agree with you. And the important part is to make the patients feel better. As far as those other outcomes, they also are somewhat problematic. Besides heart failure hospitalization, which is sort of a clean event, it's hard to impact a number of the exercise endpoints, or for example, the 6-minute walk test. Even though we have so many good therapies for HFrEF, there's only a handful of trials that have improved 6-minute walk test, which is our poor man surrogate of, VO2 max, because it's submaximal exercise, but it's an important reflection of what patients can do every day. Part of it is patients are multimorbid, and so you may impact the cardiac and or the cardiovascular part to some extent, but their 6-minute walk may not improve significantly because they have other orthopedic issues or they're obese, etc. NT-proBNP or BNP surrogates, again, may be worthwhile, at least giving a signal. Quality of life, which I think is finally a good measure for how patients feel in general, doesn't matter what the drug is or what intervention. I think that's an important point. So that would be my comment, and totally agree with you on the mortality part.
The other thing is, conceivably, I know you guys are involved in these trials, but conceivably, the endpoint, at least for you to know whether you're in the right direction, okay? Since EF, you're not going to change that much. What you're going to change is filling pressures. So I would power it to a very limited echocardiogram with mitral inflow and tissue Doppler to see whether with any of these therapies, and it could be acute, for you to think about longer term before you go to longer term and the most expensive trials. I would look at an acute within a month or two as to what you do with mitral inflow and filling dynamics at all. And if you're not affecting them, you're not affecting that part of the equation. You see what I mean? And if you do, then I would power it accordingly.
Sure.
You see what I mean? Then you'd look for some kind of improvement. And last of my questions is, we know that in these patients, relaxation is very abnormal. So if you look at the hemodynamics portion, the descent of the curve of relaxation, or tau, is very slow, right?
Yes.
Very slow. So therefore, maintaining a decent heart rate during walking activities is important. So if they get tachycardic very early, filling pressures goes very high, which leads to my question. I don't see much about beta blockade in these individuals and trials, and I think to me, beta blockers, obviously diuretics, will have something, because if relaxation is so impaired in these individuals, their E prime is usually 5 or 6 or something very low. You need that diastolic filling period to bring down the pressure.
Sure.
I don't know.
Very
I
good
mean, I'll
points.
leave it to you guys.
So just to kind of answer a couple of, so the beta blockers, Dr. Zoghbi, we do have trials. So we have the nebivolol trial, we have a carvedilol trial, we have the Edify trial looking at ivabradine, slowing heart rate. And one of the issues we've had is all of them were neutral trials. And
For mortality.
for heart failure hospitalization and mortality. Coming to the point that there has been a paradigm shift, Dr. Deswal, in terms of looking at exercise capacity as a primary outcome. For example, the RELAX trial, the primary outcome was looking at peak VO2. Same thing for the nitrates trial, the NEAT HFpEF trial. They looked at accelerometer units, or how much patients were exercising using accelerometer units, and then also with the Indy HFpEF trial. So they are moving towards exercise capacity as a goal. I think the problem we're having is the phenotyping. I think we're trying to take one medication. It may be beneficial in a sub-cohort of patients who have HFpEF.
You have to narrow it down. You really have to narrow it down, at least to take a look at it.
One question, a couple more questions, sorry, we have a few minutes left. And then the last question we're going to tackle in the end, because everyone might have something to say about that one. But Dr. Zoghbi, there's a question that when looking at tissue Doppler velocity E prime, with aging we know it reduces. What is a cutoff that you would use in your echo lab to where it's clearly abnormal?
I think what you've seen, and these are what we usually use, because interestingly enough, although there are some changes with aging, if somebody is active, still physically active, their E prime can be close to normal. So a lateral wall of 10, I think I would aim for a lateral wall of 10, 9, something like this.
Okay.
The septum is always less. So, you would like, if as you age, that your E prime stays good, because that's your index of relaxation.
Sure.
But for this diagnosis, the E over E prime is the most important, in addition, because you're looking at mitral inflow in relation to the tissue Doppler.
Sure.
In addition to something else that would go. So whenever you look at diastology, you always look not only at that particular index, but you have to put it in context with something to make sure that it makes sense. Meaning, if I have a high filling pressure, my TR jet has to be above 2.8, 2.5, 3, to tell me that my PA pressure is somewhere in the 30s.
Okay.
And most people with heart failure, you see their PA pressure non-invasively, 40, 45, something like this, right? So it is corroborative, and usually their left atrium is enlarged. It's sensitive, not as specific, because I could bring down the pressure and the left atrium stays the same. So what we use predominantly is mitral and tissue Doppler, mitral inflow and tissue Doppler, and the PA pressure, just to make sure that both of them are congruent in the same direction.
Dr. Zoghbi, could I ask you
yes.
a quick question in relation to the E over E prime and AFib?
Yes.
How do you approach that? I know there are guidelines, but what is your practical takeaway?
Actually, you can use E over E prime, provided you take few things in mind. If you have an atrial fibrillation, there are different kinds of atrial fibrillation. If you have an atrial fibrillation that is very irregular, those will change a lot. So what we would suggest in those situations is match the previous RR interval as much as possible together, because you're not doing them simultaneously. There are some echo machines that can give you simultaneous tracings of both pulse Doppler of the mitral and tissue Doppler of E prime. But if you match the previous RR interval to the E prime and the E, you could still use it. Okay, so that's one. Two, indirectly, if you don't have mitral valve pathology or annular pathology, E by itself can tell you something. because if you have much less variability, just imagine if high filling pressure, I could have a variable rate, but E stays about the same. So if I have a lot of variability in E, my pressure is usually normal or close to normal. The other two indices are one, very rapid acceleration, it's almost like a straight line of the mitral inflow, and a rapid deceleration, just like the case Imad you showed, which was very rapid deceleration, right? But you're not going to see that all the time. So that's what I would use in addition to the PA pressure. So that's, I mean, left atrial size obviously we can't use in this situation. So these are some of the tips that we could use.
Okay. Well, let me say, and because we are a little over time, but I think this is a very practical question and is a take-home point for the audience. So I would like for the panelists, starting with you, Dr. Deswal, how would you treat HFpEF in your daily clinical practice? Very practical question. We've talked about all this data. How are you managing your patients, Dr. Deswal?
Right. So I think first is the confirmation of the diagnosis. We label a lot of people as HFpEF when that may not be true. And we also have patients walking around with dyspnea and, you know, they've had complete PFTs, their resting echo looks okay. I think to go to that next step of exercise, either non-invasively or invasively, to confirm that this is a cardiac issue. So first is making the diagnosis, then is trying to separate out the etiologies. Because if I find something to treat as far as the etiology, maybe it's coronary disease, maybe like it was the AFib and RVR, or patient has amyloid or hypertrophic cardiomyopathy, I think those are really important because we have individual treatments for those. So we need to characterize those patients better. And then we're back to that whole other variety or combination of subgroups. I think, again, as I mentioned, I'm using diuretics and trying to use them well, not just putting them on diuretic and saying, okay, this is it, but actually trying to titrate it to their symptoms, treat the hypertension really well. If they've been hospitalized, but they're still not like class 4 patients, maybe ambulatory monitoring to help guide me on the diuretic and other treatments. And then one other thing we could do is try to think about weight loss and exercise. Again, not proven, but at least in small trials, exercise was beneficial in increasing exercise capacity. And then I think we're going to be waiting, put them into some of the clinical trials. And hopefully SGLT2s will have some benefit in this patient population.
Dr. Zoghbi, your clinic
Anita,
patients.
a great summary, truly. I think what we shared with you today, and you shared with us, Anita, is you have to look for the diagnosis first. And I think with our limited diagnostic capabilities before, many of these were lumped together. So I would push the diagnosis as much as possible. Many of amyloid and sarcoid patients were not identified before. And I think MRI is crucial in those situations. An echocardiogram can carry you so much, mostly from an overall EF, little structural and hemodynamics, I think still very important. So I would push as much as possible to try to identify the diagnosis in these patients, because you may find some therapeutics that you couldn't find before. And the drugs, I mean, they are the same drugs that we have for treating heart failure. Diuresis is very important. At times I stress them just to see what their response of blood pressure and heart rate is and how quickly do these accelerate. And in some of these situations, you may want to use beta blockers if you see their heart rate accelerating very fast or their pressure. You may miss actually significant hypertension with minimal exertion. I've had some patients that are just amazing actually, that their pressure would just go up very fast. So some of your diagnostic maneuvers, and you know, these have a lot of comorbidities. So if they have renal dysfunction, if they have other things, so you have to kind of choose among them. Use nitrates to decrease preload as much as possible if they cannot tolerate the other, you know, medications for whatever reason. So obviously we don't have something specific for it, but if the premise is I have a normal output, but I have high filling pressures for whatever reason, try to see if you can reverse it by looking at the etiology. And if you can't, then think pharmacologically, what can you do not to harm them and get them in the right direction. So that would be my approach.
Makes a lot of sense.
How about you?
Yeah.
Dr. Hussain?
Yes, no,
you're not going to go off the hook.
Yes, so no, so I echo everything Dr. Zoghbi and Dr. Deswal you have said. I do feel like that for the obese HFpEF patients in my clinic, I send them to cardiac rehab, and I send them for bariatric surgery if possible, and they have witnessed a significant improvement in their symptoms. Someone has persistent AFib, I go for rhythm control strategy, because there has been a lot of data that shows that their peak VO2 measured by exercise capacity, and there's some data to suggest even the mortality improves with rhythm control if it's sustainable, because it is hard to sustain normal sinus rhythm in AFib patients. And lastly, between Dr. Guha, who is one of my colleagues, and I, we have a cohort of 40 patients that have two types of etiologies: exercise-induced HFpEF that have benefited from being on Entresto. And they have had improvement in NYHA class, improvement in 6-minute walk distances. We have not published this literature yet. And then we have a sub-cohort of patients within HFpEF that have a pulmonary vascular resistance of over 5, where we have used sildenafil with some benefit. Now, these are anecdotal. They are actually contrary to the guidelines. I want to point out to the audience that the guidelines give a class 3 recommendation to sildenafil, but they're giving it to the garden variety of HFpEF and the whole kingpin of why these trials have been negative. So these are some additional thoughts from my end. But I really thank you, Dr. Zoghbi, for the last moment of coming to rescue us. Dr. Deswal, for your time. And thank you, everyone from the audience, for joining us for what I thought was a great session going over heart failure with preserved EF. Thank you very much.
That's great. Thank you.
Thank you. Bye.
Bye-bye.